Thank you very much for this award. This is not my first visit, and I have fond memories of coming for the TOC Oration Award a few years ago as well. But it's always a pleasure to be back here. Uh, when I was asked to select a topic, I obviously chose something to do with corneal surgeries, but then I had to tread a little carefully. So the criteria for selection of the surgeries were those that I do, which I think you should also do. Then those which are not being discussed at length by the other speakers, I was careful not to tread on too many feet. And those, hopefully, that will not induce pre-lunch slumber in you. So let's go ahead straight with the topic as we are a little short of time. Let's start with the first one, conjunctivoplasty with corneal tattooing. Dr. Siddharthan told you about how easy the corneal tattooing is. Gunderson, 1958, was the first to describe a technique using the conjunctiva without tenons. We are now used to using conjunctiva without tenons in pterygium surgery. Apply the same principle for conjunctivoplasty, and it's not difficult at all to do. So any corneal opacity with poor visual potential with an irregular surface causing symptoms such as aphakic or pseudophakic bullous, a patient with a neurotrophic keratitis, non-healing corneal defect in a blind eye, staphylomatous lesions, all of these do very well with the conjunctivoplasty. And in many of these, you can combine it very easily with tattooing at the same time. So if you see this bullous keratopathy patient, you scrape the epithelium off and you use the tattooing gun. This is Amazon available 500 to 700 rupees, India ink, a black ink which is available. And because I'm showing it on video, we have an autoclaved cloth around the tattooing gun. It looks better. So you first finish the tattooing part exactly as Dr. Siddharthan showed us. You can repeat it multiple times. It hardly takes 5 minutes to do the complete tattooing. When you scrape off, you realize that nothing is coming off. That means it has gone fairly deep into the stroma. Then you proceed with the conjunctivoplasty. In the conjunctivoplasty, you need a good assistant to do this. You dissect the conjunctiva all around. You don't worry about limbal stem cells here because this is in a blind eye. So you do a peritomy 360 degrees. Then the assistant lifts the conjunctiva up. And using a blunt Westcott scissors, you dissect under the conjunctiva, making sure you don't include any tenons. So the first part you do yourself, but then after that you need an assistant. Therefore, I always say that choice of music in the theater should be the one which the assistant likes. Chop off the unnecessary tenons which is there, making sure you don't chop off muscles. So this is crucial so that you don't get a retraction of the flap. So this is where the assistant has to hold the conjunctiva up towards, pointing towards the sky and pointing away from the cornea. And you chop off tenons. The more the tenon you chop off, the more elastic the conjunctiva becomes. And then let him drop it and pick it up at a new place, at two new places, and dissect, blunt dissection so that the conjunctiva should be almost transparent at the end of it, and chop off the tenons again. Don't go too deep because otherwise you'll cut this orbital septum. The moment you find orbital fat coming out means you've chopped the septum, which is not required. So he's dropping it there. He'll take it to a new place and cut again. So you can go around once, twice, even 3 times and remove bits of the tenons every time, till such time as when you pull the conjunctiva over the cornea, almost 4/5 of the cornea is covered very easily without any tension. So here I am pulling it across. I am finding that it's still not coming fully. I'll cut again. I have made a small hole in the conjunctiva. Here, buttonholing, it doesn't matter. You can suture it with a polyglactin suture. So I am deliberately showing a video in which I have made a small complication. I take a single mattress suture and close that. Then I make two cuts in at 4 and 8 o'clock position at the limbus. You have a laser pointer? Yeah. At 4 and 8 o'clock limbus, you make two cuts, and with 6 or polyglactin sutures, take a mattress suture on either side so that you anchor it from top to bottom. This one. Yeah. And then the others can be closed with 7-0 or 8-0 polyglactin sutures. I take multiple sutures close to each other. It can be done interrupted or continuous as you like. I prefer interrupted sutures, prevent dog earing of the wound, and that is the end of the procedure. So results are usually long lasting. Retraction is uncommon. It provides tremendous symptomatic relief, can help heal even corneal non-healing ulcers when you're not doing it with tattooing. A fungal ulcer which is not healing, you cover it with this. Continue with the antifungals, you can prevent a perforation, and then 6 months later you can do an optical keratoplasty very easily in these patients. Post-op management is not difficult. Antibiotics for about 2 weeks, atropine if indicated, steroids unless you're dealing with a fungus ulcer for about a month, and oral painkillers SOS. Let's move on to plugs, snips and MMG. So management of dry eye traditionally is lubricant drops, gels, ointments, depending on which medical rep visited you last. Some of you might experiment with immunomodulators like cyclosporin, topical chloroquine, trehalose, now even lifitegrast. Blepharitis you would treat. Careful people would look for Demodex and treat this when MGD would be treated. Aside from the medical management, there is a small role for what I call plugs, snips and MMG. So plugs in aqueous deficient dry eye, not on the first visit, I would start topical cyclosporin drops to improve the quality of the tears. I always give the example of a basin, which is you don't put a plug if you want to use the water in the basin with the tap open. Don't put a plug in the initial. Make sure that the water which is flowing is clean. If it's dirty water, you're not going to use it. So allow the cyclosporin to act for at least a couple of months. The quality of the tears improves. Then I insert collagen plugs in all the 4 puncti. If the patient feels a wow effect in 24 to 48 hours, then you can counsel for permanent plugs after about a week. You can use punctum plugs, lacrimal plugs. If post-LASIK, you can use 90-day dissolving plugs. We had these for quite some time. So these are the available plugs that you get. You get punctum plugs which sit in the punctum, and every time patient comes to you, you can see it on this clamp, gives you a lovely sensation, and you can tell the patient that it is still there, because when the patient's dry eye worsens, because there is patients feel better on certain days. First thing he come to you, I paid you for punctum plugs and it's no longer there. I think they're gone. So punctum plugs is good because you can always show the patient it is there. But my preferred choice is the lacrimal plugs which go inside. These are the Herrick lacrimal plugs that I use. They come on a stiletto, on a stillet like this, and they are shaped like this. They push in, you remove this stillet and this occupies space inside. You can't see them from outside, but you can trans-illuminate these plugs and you can show them to the patient that they're still there. You can of course use punctum cautery, especially a lot of work from Shankar Nethralaya about use of cauterization of the punctum instead of using permanent plugs. So there are many ways to skin a cat. So that was about plugs. About snips, again, what the mind doesn't know, the eye doesn't see. So look for a condition called conjunctiva chalasis. Conjunctiva chalasis is nothing except the lower conjunctiva forming ridges between the 6 o'clock position of the cornea and the lining of the lower lid. So if you find loose conjunctiva, you don't even have to stain. You can see this forming like a loose area. So the tears collect and well up over here and don't lubricate equally around. So patient gets dryness. So this is, if you look for this, you can see it. As I said, you don't even have to stain, but looking for it, knowing that something like this is there, and that a simple surgical procedure is available to you for solving this issue. So what you do is you just pull the conjunctiva at the 6 o'clock, say about 3 to 9. Avoid touching the stem cells, of course. Take about 2 to 3 millimeters strip off, just snip it off, and then pull the remaining conjunctiva up. It's all quite lax actually, and glue it into place. You can suture it, but gluing it makes more sense. And that's the end of the procedure. You can do both eyes at the same sitting. Just glue it, pinch it, and fix it. So this was snip surgery. And something that I learned from Dr. Geeta Iyer, the lid viper epitheliopathy. Again, this is something which if you don't look for and you don't know about, you will never treat. So in chronic Stevens-Johnson syndrome, where you get lid margin keratinization, LWE is lid viper epitheliopathy, LMK is lid margin keratinization. You need to look for these keratinization. And what happens is that every time the patient blinks, this keratin, which is rough, rubs against the cornea and causes corneal abrasions and causes the patient to be completely symptomatic. So you can reduce this. So this is staining with lissamine green. You can stain with whatever you want. The principle is that you remove the lid margin keratinization as much as possible and replace it with mucous membrane graft from the mouth. I was doing the mucous membrane grafting for my Pintuchis way back from 1997, so it was fairly easy for me to do this. You see the amount of keratinization which is there. So you need to remove all the keratinization. Once you created a raw surface, you take the mucous membrane from the mouth. You can do upper lid and lower lid together. You can do all 4 lids at the same time, depending on the need, and you can use appropriate anesthesia. Can I have a water? This is the Calazion clamp type instrument I use for my Pintuchis. So I just hold the lower lip down and I mark the mucous membrane. You can take a little thickish graft and thin it out later. I use hydrogen peroxide on the lower lip. It stops the bleeding fairly easily. Then you can thin out the graft as much as you like. And then you can use either sutures and glue or a combination of both to stitch it back in, to stitch it into place. It's a very rewarding surgery at the end of the day. Moving on to pterygium surgery, again something that is fairly, all of us see so much of pterygium. I don't understand why all of us are still, even in 2025, not doing a conjunctival autografting for pterygium. I still see patients with bare sclera technique, the pterygium being given to the junior most resident who simply yanks it off and applies a little bit of cautery and comes out of this. So I am a great proponent of mitomycin C in pterygium surgery from Dr. Joseph Fruch Perry of Israel, who pioneered this procedure. If you use it along with conjunctival autograft, all your problems of scleral melts are much reduced. So of course you cannot use MMC without a conjunctival autograft. You must use it with a conjunctival autograft in every case. So I would recommend that we do a conjunctival autograft surgery for all pterygiums. There are other things like rotational grafts, double conjunctival grafts, annular grafts. The perfect technique which came in, which stands for pterygium extended removal followed by extended conjunctival transplant. You don't need to do so much of surgery, especially if it's a first time pterygium that you're doing. This is not a new surgery. Dr. Kenneth Kenyon, who has come several times to India, was my presidential guest during my presidency in 14-15. So I learned this from him, the free conjunctival graft from superior temporal bulbar conjunctiva, and he recommended it for both advanced as well as recurrent pterygia as well as primary pterygia. And this is from Dr. Donald Tan, again a surgeon whom I admire. This is, since I could never show you a picture of such good results from my own slides, The videos are mine, but this slide is borrowed from Donald Tan to show you how excellent you get cosmesis after this. Again, important thing is that take care of the tenons layer. Don't dissect conjunctiva for the graft with the tenons. You must dissect away from the tenons, and that's the only thing basically you have to learn. It's not a very difficult thing to do. How you remove the head of the pterygium, whether you go from head first, whether you go from the body first, whether you yank it off, whether you dissect it. These are all minor differences which everyone will have. The results are almost equally good in whatever technique you employ. I use a diamond burr polisher for my patients ever since the 80s. Remove more of the subconjunctival tissue than the actual conjunctiva so that the defect is not too big. This is the diamond burr. Earlier this was mechanical. Now I've got from Epsilon, no financial interest, motorized burr that I use to smoothen the surface. Measure. Make a marking on the superior conjunctiva. You can make it only on 3 sides if you like, and take a tenon-free graft. And again, you can either suture it, you can glue it, you can use the patient's own blood to attach it, whatever you are comfortable with. If you're using the patient's own blood, please wait for some time for it to, and press it well for it to stay in place. And when you put the upper lid, when you're closing the eye, do it manually, pull the upper lid over so that you don't dislodge the graft. Again, important to get it tenon free. And then the rest is tailoring. So tips for success: take a large, generous graft, a thin, tenon-free graft, make it stable. Don't, in your initial phases, don't be led away by people showing you videos of how wonderful sutureless it was. Take anchoring sutures, anchor to the episclera. I used to take anchoring sutures to the middle of in the middle of the bed, so that whatever happened, at least my whole graft wouldn't get lifted off. You can use, as I said, glue or various other things as well. Moving on to allergic conjunctivitis. We all know that we have a surfeit of drugs now. You have bipotestin, you have alcaftidine, you always had patenolol, and before that you had the disodium chromoglycate, which I hope no one is using now with the newer drugs available. But still you have patients in whom, besides steroids, nothing really works. And sometimes you get patients in whom just the bulbar conjunctiva is fairly free of allergic conjunctivitis, but the palpable conjunctiva has got these thick papillae, cobblestone appearance. So in these patients, I have been using this technique, a surgical option, where you scrape off the papillae and then either you can put a mucous membrane graft again from the mouth, or you can use amniotic membrane. So as I said, since I'm familiar with buccal mucous membrane from 1997 onwards, this is what I've been using. This was the very first case that I did when I wasn't sure what knife to use. So you will see Bart-Parker 15 number, Bart-Parker 11 number to scrape off the papillae. So in this patient, I've taken the conjunctiva, taken the graft from the bulbar conjunctiva, just like you would do in a pterygium. I've also taken buccal mucosa. In this patient, what I did was, I took only the central portion, where the papillae were, and the peripheral ones were left untouched. When I did that, I found that recurrence occurred in the area which I had not touched. So now when I do this in refractory cases, I prefer the buccal mucosa because I can take a large quantity and I scrape from one end of the lid to the other, even in the normal areas. This was a patient whom I saw in COVID, a patient with nevus of Ota. So I call this blue, black, and white scleral explants for nevus of aorta. This I did during COVID time. This was a young lady from Gurgaon, from Delhi, who was very mentally disturbed, recently married, but still mentally disturbed, which just shows that marriage is not the panacea for all evils. With this condition in only one eye. So she came to me asking for help. I told her about scleral lenses and cosmetic scleral lenses. She didn't want to try them out. So she was very keen for surgery. Her marital relations were affected. She was not happy. She had tried all sorts of homeopathy, Ayurveda, etc. And the lockdown was making matters worse because it was only she and her husband. And every time she looked at her husband, she got some weird inferiority complex. I talked to the husband separately also. He was quite okay with this. He says, I married her with this nevus of aorta. It hasn't come post-marriage. But she wanted something. So I looked up literature. Some Korean studies had been done on scleral explants. I did UBM, found the scleral pigmentation extended 350 to 400 microns. So I visited our eye bank, used the automated microkeratome, used blades obviously, to prepare many postage stamp bits of sclera, approximately 350 microns. I purchased 350 micron disposable blades with handles and opened the conjunctiva 360 degrees, 2 to 3 millimeters from the limbus. I shaved off approximately 350 microns of sclera in all the affected areas, almost 10 to 11 clock hours. Each dissection not more than 3-4 clock hour size, not more than 5 millimeters square. This was sutureless surgery. Applied fibrin glue and stuck the similar pieces of donor sclera in the dissected area. So scraped off the pigmented area and stuck the eye bank sclera there. And then I glued the conjunctiva back into place. So open conjunctiva almost 360 degrees. The quality of the video is not very good. I thought I'd lost the video and then found it later on. But you'll just get the gist of what I was doing. So I'm scraping, I'm with a lamellar blade marked 350 microns. I went up to that depth and then cut off pieces like this of the sclera, with the pigment in it. So almost 360 degrees. Then I took the earlier prepared lamellar scleras, applied glue and stuck these into place, postage stamp styles. I had no previous guidance. I had rung up Dr. Somashila Murthy, who was supposed to be an expert on sclera, and she said, I have never done this, you'll figure something out. And then brought the conjunctiva on top and just stuck it into place. And this is how it looked at the end of the procedure. This was the immediate post-op. 1 month post-op, pictures taken by the patient at home in Delhi because COVID was going on, so she couldn't come off. And this is 4 months post-op. And this is the February 22 pre-op and the April 24 post-op. So if the patient is seen from a distance, she is quite happy with this. She still feels it jutting out a little. I agree with her. The next time I get a patient, I will make even thinner scleral patch grafts. Maybe I will not even make patches. I will make a full circular ring so that it looks better. So take-home message is under promise, worth attempting lamellar patch grafts and blue nevus of aorta if patient is keen and motivated. Post-op appearance is definitely better, and it's sutureless surgery. Appearance, I found that it didn't. I kept assuring her that as time goes by, it will look more natural. Nothing like that. It's just trick photography you can do to make it look better. But the appearance at 1 month and at 2 years post-op are almost the same, but patient was definitely happier. Incidentally, patient is now the proud mother of a girl child. I'm not saying that I caused fertility, but still. Corneal laceration we talk about. Again, just couple of principles. Wash thoroughly, look for trapped eyelashes. If less than 2 millimeters, can use tissue glue. Dry the surface, remove the epithelium and use a bandage contact lens. If it's greater than that, you need to suture. My choice of suture is 10 or nylon, and go approximately 90% depth, because if it's shallow, you'll cause a posterior wound gape, and go equal on both sides of the wound. So on both sides of the wound, if this is the wound, you go equally on both sides. And if the closer you are to the visual axis, the shorter the bites. The further away you are from the visual axis, the longer the bite. So this is the principle of repair, because in the periphery you want compressive sutures. You want to reduce the astigmatism. In the center you want no scarring. So you want just to oppose the edges. So these are the principles that you need to keep in mind. Larger, longer bites in the periphery. If the wound is oblique, then equal length of each pass as measured from the posterior aspect. So from here to here is the same as from here to here, not from the anterior aspect. So if it's an oblique cut, you need to measure from the posterior aspect. So this bite may be closer to here than that bite, which is perfectly all right. Keep the iris away when you are suturing this. Uh, you can do continuous suture if it's clean. Now, my choice of suture is again, as I said, 10O, but in 10O, try and use a 180-degree needle. You get the Oral Lab needles, which are AS 140, AS 160. I got them to make AS 180 for me, which is 180 degrees curved, so that you can get equal depths, and at right angles it becomes easier. The other ones which were there earlier, Johnson & Johnson had CS Ultima, and Alcon had AU5 needles, which are all 180-degree curves. So you need to remember, the more the curve the needle, the easier it is to take equal bites. The tighter the suture, the more the steepening. So you can do intraoperative keratometry as well. So first make sure that you have a wound, it's lamellar, it's full thickness, you need to check that out. And I normally inject air at the end of the procedure. I think we'll skip this video because I'm looking at the clock at the same time. You've got the principles in mind. So if the cornea scleral laceration, close the limbus first, then close the cornea, then open the conjunctiva peritomy and keep following the scleral wound. Keep suturing with 7O polyglactin as you follow the wound after removal of any vitreous which is there. Sometimes you might have to disinsert the muscle as well, but take stay sutures so that you can reattach the muscle if the wound is going under the muscle. When do you remove sutures? Remember that in children, the healing is very fast. So in about 4 to 6 weeks, you should be removing the sutures. In kids, the younger the kid, the faster you remove, and do it under general anesthesia. If it's an adult, you can remove alternate sutures, and then 15 days later, you can remove the others to make sure that the wound is well healed. We'll go on to SLET, which took the world by storm. Dr. Virendra Sangwan et al. From LVPI showed such lovely long-term results of SLET in cold cases of chemical burns with over 70% success rate. These pictures belong to Dr. Sangwan's initial series. So again, it is something which is superb for patients with unilateral chemical burns, and many of our patients do get unilateral chemical burns because we get young children who play with tuna packets and press that tuna packet and it goes into the eye, and you get horrible symlephra, but the other eye is not affected. If that is so, you release the symlephra as much as you can. I hook the muscles also to find out, to make sure that everything is clean. So you can hook the 4 recti. You put an amniotic membrane, then you put the SLET pieces as Dr. Geeta showed you. She showed you allo SLET, but here you can take it from the patient's other eye which is not affected. You can use fibrin glue. you can use some amount of conjunctiva so that you can hold on to it. Then take that cornea bit that you got and cut it into at least 6 to 8 pieces. You can use some amnion to close it over. Put those small pieces onto the cornea and stick them there with glue, and then you can put a bandage contact lens on. I move on to the keratoprosthesis. I've done a lot of these Pintucci keratoprosthesis. I must warn you about doing keratoprosthesis. It is not very safe surgery to do. Dr. Pintucci, who invented the keratoprosthesis, died young out of stress because his family fought with him, as people in Italy are known to do with each other. And he went to Africa to recuperate from the stress, got a massive heart attack and died before he was 60. So it's deleterious to the health of the surgeon. The patients are also not very happy. This was a lady whom I did a Pintucci. 5 years later, she complained to Dr. Pintucci in Rome, saying that I am very unhappy with this surgery because when I go to play cards in my kitty group, people look at my eye. She was 6/9, and I gently explained to her that, ma'am, you were PL, perception of light. You were not playing cards before. You are now playing cards. No, but the people look at my eye. You see, I'm not smiling. So she was in depression. Pintucci asked me to devise an artificial prosthesis or something on top of this. It's difficult to do. So patients are not happy. The surgeon dies early. Not a very happy situation. This is the Pintucci K-Pro materials. The optical cylinder was medical grade PMMA, which is very similar to the MOOKP. This is the optical grade. Instead of the tooth part which you have here, you have a cloth. Dacron is cloth, just like the sari material, which is 0.6 millimeter thickness. So this thickness is 0.6 millimeters, and Pintucci stuck it into this by a patented technology which he never taught me. So advantages of Dacron that it is soft, pliable, easily cut into desired shape, autoclavable, it's inert, gets easily colonized and no resorption. This was a patient whom I did in Malaysia, in Kuala Lumpur. This gentleman was blinded by an acid attack. He had about 18 different surgeries, 18 surgeries done prior to this. He got back something like 612 after the procedure. This was in 2006. And 5 years later, the eye surgeon from there called me up to say that this patient died. And said, I'm sorry to hear it. He's saying it was your fault. You realize that. I said, what happened? So when a patient sees also the surgeon is blamed. Patient was a milk vendor. He was crossing the street at 4 a.m. with his milk van, holding the milk can because he could see. And a truck who couldn't see him knocked him over and he died. All these years he was sitting at home and he would have been alive if not for your keratoprosthesis. That's why I said Pintucci keratoprosthesis not very good. Successful patients are not happy and the surgeon dies young. This was the unhappy patient in depression. This is the video of the procedure. It's done in 2 stages. So you take the Pintucci, hold it in a special clamp, put it under the lower lid for 2 months and allow it to hibernate there. Just close it again. And at the same time, you can open the eye and release all the symblepharon and put a buccal mucus graft. So this was a patient. The advantage is that you can do it, unlike in a Boston K-Pro, you can do it in bone dry eyes. The indications for MOOKP and the Pintuccis are practically the same. So I find I put a 10 nylon suture in the center of the cornea because then I will know how to identify the center. This is the lower lip being held in the clamp, just like I showed you earlier. And I take out a large piece of buccal mucosa. Be quite generous with this. I use hydrogen peroxide, as I said, to stop the bleeding. I thin it out a little bit and I suture it to the 4 recti because the 4 recti have got blood vessels. So because this is a free graft, So the 4 recti will bring in blood over there, keep it for at least 2 months, sometimes 3 months, and put a conformer there so the patient doesn't see anything after the first stage. In the second stage, you find the K-Pro. It's easy to find because there's a bump there. You clean it up. Now the Dacron mesh, which was just 0.6, has become quite thick because blood vessels and fibrous tissue have grown into it. You reflect the buccal mucous flap somewhat less elegantly than you would reflect a LASIK flap. Reflect it so it stays on one side. Then I make 3 cuts in the cornea. I remove the central disc, earlier 3.5 millimeters, now 4 millimeters. I remove the iris, I remove the lens, whether it's a crystalline lens, cataractous lens or an IOL, it doesn't matter, they all have to come out, unlike in a Boston K-Pro. Then I suture the cuts together, I put this on, I suture this with 6O Vicryl to the surrounding sclera. The buccal mucosa, which was tethered at one point, is closed on top of this. Now you can see the Pintucci K-Pro shining through, so you make an opening in that. This is just to show off that I have a diamond knife. You could use any knife for the procedure. This is the end of stage 2. Patient should see 6/9. The Boston K-Pro, my 16-year odyssey since 2009, it is the one that I use. Has got a front plate which is mushroom shaped. Then you have a corneal graft in which this fits in. There is a back plate which initially had 9 holes or 8 holes. Now it has 16 holes. And there is a titanium locking ring. There is a variation to this called the Lucia, which doesn't have a locking ring. The back plate itself is titanium. But I have been using this all along. So this is my first patient. I did it for a patient with a divergent squint. I thought it would be amblyopic. I could try this out. To my surprise, in spite of that, he got 6/12 vision, in spite of divergence. Last 5 years or so, I've switched entirely to the Oro K-Pro. It's excellent quality, manufactured under license from Boston. I've been using since several years now. And I use the Adi glaucoma drainage device from Oralab many a time along with this, because later on it's difficult to do glaucoma surgery in these patients. So this is the Adi in a patient in whom I'm going to do the K-Pro. I push the Adi in. You can trim it later. You can trim the tube later. You can use the patient's own cornea to cover the Adi valve, the tube. So I scrape it on both sides. And I use that itself to cover the tube. And then proceed with the Oro K-Pro. So the Oro K-Pro comes in with two back plates, either a 7 millimeter back plate or an 8.5 millimeter back plate. So you usually for an adult you use 8.5 back plate. So the trephination is 8.5 of the patient's eye, and 9 millimeter is the donor cornea that you use. You might want to open the pupil a little with multiple sphincterotomies if there is no round pupil. You need to remove the lens, or you use what is called a pseudophakic K-Pro. If you're pretty sure that the lens is in the bag, which you're never sure, so I prefer to make it aphakic. And when you order, you order a particular axial length. Depending on the axial length, Oro-K-Pro or the Orolab people give you a particular power. So this is a patient whom I did recently in Sri Lanka when we went in September for a conference. The patient was from Pakistan, Lahore. He couldn't get a visa to come to India. So I requested the Sri Lanka people to allow me to operate him there. And this is the patient running around the hospital waiting room, unaided, was blind for 5 years with chemical burns prior to that. To conclude, therefore, knowing which cases to do, what surgery is good. Knowing how to do the surgery is less important. You can be acquired by watching enough surgical videos of the procedure. Knowing when a surgery is not indicated or when it is beyond your expertise and referring it to the appropriate expert is possibly the best take-home message you could pick up from this oration. The original 10 commandments of Moses. See, I was on pilgrimage in Iraq for the last 10 days. And when I got a message from here saying that you need to give 10 commandments, and I had no idea what 10 commandments to give. So since I was brought up in a Catholic school, I recalled the 10 commandments that Moses originally gave, and then realized that Moses had actually written it for the audience which is here. So we'll go through the 10 commandments. The first one was, you shall have no other gods before me. If you take an ophthalmology, please don't covet the plastic surgery or ENT or wish I could have been a lawyer instead. So once you've accepted ophthalmology as your God, you stick to that. You shall not make unto thee any grave images. What do we mean by grave images? That means you are an ophthalmologist, you're supposed to treat the blind, restore sight. Don't look at Mercedes cars. Don't keep that in focus, your Mercedes cars or a fancy house or something like that. Nothing should be before your God. You shall not take the name of God in vain. You are careless with your techniques. You cause endophthalmitis and then you take the name of God. You pray to God only at the time that you want help and succor from the end of patients. Should not be done. I like the observe Sabbath day. Sabbath day is one day in a week in which the Jews don't touch any metal instruments. I find doctors, eye surgeons who are full-time ophthalmologists, 7 days a week, they practice, they operate. I think you need to have some family time. But the second presidential guest I got was one Dr. Sherwin Eisenberg, a squint specialist. From USA, he told me that please make sure that my lecture is not on a Saturday because I will not touch the microphone on Saturdays. So the point is not but to take a break at some point, be with family, at least know how your children are doing. I know of a busy ophthalmologist in Mumbai who didn't know that his son had failed in the 7th standard. His wife successfully hid it from him because he was so busy in practice. That should not happen. Honor your parents again is a no-brainer, absolutely. They brought you this far, you need to take them with you the rest of your way. Don't kill this, I've just put it crudely. Don't kill somebody else's practice by saying, which butcher did this to you? Thank God you've come to me, I'll now help you. So don't kill somebody's practice because that person will kill your practice someday. What goes around comes around. Don't commit adultery, which is again, stick to your own profession. If you are a cataract surgeon, don't dabble with intravitreal injections just because it looks easy to puncture the eye. I still I've not done a single intravitreal. I call in a retina person to do it for me. So stick to your wife, stick to the one, or stick to your spouse, the one that you have chosen in your super specialty. Don't steal. Don't steal patients from others by unethical means, by showing that you have got a better phaco machine than that person has. That's not the way. Show your prowess. Discuss your complication rates, but don't steal from others using unethical means. Don't bear false witness against your neighbor, which is very related to this one. And you shall not covet is the 10th commandment. So be happy with what you have. Don't be jealous of your neighbor's Mercedes car because you don't know that with that Mercedes car, he's still got unpaid EMIs, hypertension, diabetes, and is going into mild depression. All of which you don't have. So don't covet, be happy with what you have. And I think all of us will be happier, better surgeons. Thank you so much for your attention.